Hello everyone, thank you for joining us and welcome to this educational webinar on the importance of SPE and A1AT phenotyping for better alpha-1 antitrypsin deficiency patient management. I am Rafael Kesh, Global Product Manager at Sebia, and I will be your moderator for today's session. So I would like to welcome now our speaker, Professor Simone Scarlata. And Professor Scarlata is member of the European Respiratory Society, of the Italian Society of Respiratory Medicine in Elderly, and of the Italian Society of Geriatrics and Gerontology. He is also member of the editorial board of the Biomedical Journal, the Open Chemical and Biomedical Methods Journal. He has carried on his activities at the University Campus Biomedico of Rome, and is notably responsible for the activities of respiratory physiopathology and sleep medicine, appended the area of geriatrics. He has also done formal teaching and clinical tutorship for students of the Campus Biomedico Medical and Nursing School. Professor Scarlata is author and co-author of numerous publications in national and international journals. So before starting, we suggest you to use the full screen option to better see the slide of the presentation. Please also use the question tab on the side part of your screen, and we will answer as many questions as we have time for at the end of the presentation. So Professor Scarlata, so thank you for joining us today, and the stage is yours.
Thank you. Good morning, everybody. It's a real pleasure, and I'm so glad of being here. Thank you for inviting me, and thank you for the support in preparing this speech and lecture. I'm very happy to highlight today the importance of two diagnostic tools in the management of an early diagnosis of patients with alpha-1 antitrypsin deficiency. These two very important tools are the SPI and the immunophenotyping that, in my opinion, and I will try to make you convinced of that, represent two important instruments deserving implementation. Let me first highlight and outline the presentation I would take today. I would briefly explain you and introduce you to the genetic epidemiology and clinical features of the alpha-1 antitrypsin deficiency, just to make you aware of the clinical burden and importance of assessing patients with this problem. I also will convince you that treating patients with a deficiency may provide relevant and dramatic results in terms of clinical outcomes. I will try to guide you through the recommendation and guidelines leading to a proper alpha-1 antitrypsin deficiency diagnosis, and I would try to suggest you to ask you if there is any room for population screening in order to unveil the large hidden cohort of people with alpha-1 deficiency by using instruments such as serum protein electrophoresis or even isofocusing. Isofocusing, that is going to be the conclusive part of this presentation, and that, in my opinion, may be a relevant issue to be focused on. First, allow me to start from definition of alpha-1 antitrypsin deficiency, that according to guidelines is a genetic autosomal recessive disease characterized by the low serum level of alpha-1 antitrypsin. This predisposing to chronic obstructive pulmonary disease, especially emphysema, but not only, including also liver disease and more rarely other multi-organ vasculitis or even necrotizing paniculitis. This is important to highlight that indeed we should define this disease not as a recessive one, but as a codominant, since we are now aware that even intermediate deficiency or heterozygosis for mutation may carry some relevant clinical issues and a clinical feature. So we should better define this as a codominant disease. This is something that we should really keep in mind for the rest of the lecture. What about the alpha-1 antitrypsin in terms of genetics and molecular aspects? This is a high molecular weight plasma glycoprotein that is mainly produced by hepatocytes that are responsible for the most circulating alpha-1 antitrypsin level. But we have to remind that this is also produced in smaller amounts by other cell lines such as monocytes, macrophages, pulmonary alveolar cells, and intestinal epithelial cells. The main function of alpha-1 antitrypsin is counteracting and inhibiting the neutrophil elastase. That is an extracellular protease that is very important in balancing the inflammatory process into the body and especially into the lungs. The alpha-1 antitrypsin is typically very abundant into plasma, reaching a mean concentration of 1.3 grams per liters, and showing a plasma half-life of about 4 to 5 days. What about genetic? We know that alpha-1 antitrypsin is encoded by the SERPINA1 gene, cited on chromosome 14. This is a very and highly polymorphic gene, and we are aware of about 200 mutations, most of them carrying with a deficiency pattern or bad functioning pattern related with a wrong folding process or influencing the glycosylation of the protein and therefore its function itself. Typically, we used to classify the mutation according to their phenotypic expression and their electrophoretic mobility during isoelectric focusing. So we are used to define the normal phenotype as the PIM, and then we define the most common, the commonest pathologic phenotypes as the PIS and the PIZ that we are going to see more in focus briefly. It's very important to say that we need to have a reduction in plasma levels below the threshold of 35% to be able to define a severe deficiency state. And we have to be aware that such a condition realizes when the point mutation occur in a glutamic acid to lysine at position 342 in the SERPINA1 gene. We refer at this mutation as the Z allele, and this is something we should be aware. This is a list of those frequent combination in alpha-1 antitrypsin gene mutation, these are not leading to pathological consequences. We have the MM state genotype that occurs in 81% of the population, and it is associated with a normal protein activity, as well as the FM genotype occurring in about 5% of the population, again associated with the normal protein activity. Then we have to remember that there is the heterozygosis for S variant, the so-called MS, occurring in 70% of the population. that is not considered as a pathological pattern because the protein activity is quite high and about around 80%. Very importantly, we are to name and to cite the MZ variant occurring in 3% of the population with an average protein activity of about 56%. This is a list of those variants associated with the pathological conditions. Of course, we have the homozygosis for the Z allele. This is quite rare, occurring in less than 1% of the population, but this is associated with a very low protein activity, meaning that the proteases, antiproteases balancing is very, very at risk. Together with the SZ variant, carrying with 36% activity of the protein. I included again the MZ variant in the list of those variants associated with pathological conditions because in some cases when the abnormal genotype associated with the clinical and environmental risk factors such as smoking or other kind of exposure, the deficiency, although intermediate, may be associated with the relevant clinical pathological features. Here we see very, very easily how different phenotypes and genotypes are very, very strictly associated with circulating alpha-1 antitrypsin serum level. We see that we regard using the normal variant as a reference, we observe a progressive reducing in circulating level according to the different phenotype and genotype we observe. Noteworthy, we should say that we recognize an intermediate deficiency area with a circulating serum level of alpha-1 antitrypsin between 0.5 and 0.9 gram per liters, and a very severe deficiency area when this threshold is passed through and the patient starts to develop a very, very high lung function decrease of disease progression due to the low alpha-1 antitrypsin levels. This is very important to remark that other than Z and S variants exist, and they may have a relevant role in clinical practice. Taken together, the rare variants account for about 7% of all pathological phenotypes, and this meaning that this should be taken into account when searching for mutation in selected patients, high-risk patients. This is a study made by our group that confirmed this preliminary evidence, and again we observed a 7 to 8% prevalence of minor and rarer variants in deficient subjects. Few words about the epidemiology of the alpha-1 antitrypsin deficiency. This is the distribution worldwide of PIZ variants, and as you can see, this is very highly distributed in Northern Europe and Western countries and South America. The reason why the frequency is so high in Northern Europe is because the mutation is likely appeared and born in Scandinavian area, as from then has been diffused and moved around the world. Similarly, this is the distribution worldwide for the Has variant. Again, the place where it is much more frequent is the Iberian Peninsula, and a Mediterranean area, together with the Western countries, and very noteworthy with the South America and South Africa regions. Taken together, this is the frequency of gene mutations stratified according to geographic regions of the world. This meaning that despite disease, and this can be considered as a rare disease, however, there is a wide difference between different areas in the world that should be taken into account. However, there is no doubt that alpha-1 antitrypsin deficiency is currently a severely and badly underdiagnosed condition. We can estimate that about 1 out of 5,000 people in Europe suffer from a severe alpha-1 antitrypsin deficiency. Unfortunately, to date, we can estimate that only 10 to 15% of all those carriers for homozygosis have been diagnosed. And again, there is a dramatic 6 to 8 years delay occurring from symptoms onset to final diagnosis, and this is a real issue in clinical practice. The reasons for these are mainly due to a lack of knowledge and awareness between the healthcare providers and the patient themselves. This study conducted in Italy and Germany shows how, despite the clinician background, being it specialistic, being the clinician involved in respiratory medicine care, there is an underestimation of the problem and the lack of knowledge and awareness in all the study group that may be responsible for this lack in diagnosis. And this is a pity, because if you consider the prevalence of many other rare conditions, such as sarcoidosis, cystic fibrosis, Wegener's granulomatosis, and so on, we see here how alpha-1 antitrypsin deficiency is more frequent than these other diseases that have conquered a relevant importance in clinical practice. And this meaning that there is room for an improvement in awareness and clinical approach to this patient. Let me say a few words about the clinical presentation. I'm aware that most of you are not involved and actively involved in clinics, so I don't want to go too deep in these. However, let me briefly say how a patient with alpha-1 antitrypsin deficiency may present in clinic. Infants typically show very mild or undetermined symptoms, such as poor feeding, poor growth rate, or sometimes specific hepatic liver disease and conditions such as cholestatic hepatitis. In the adults, clinical presentation and feature involves typically respiratory and liver conditions such as emphysema and soft tissue panniculitis, as well as asthma, bronchitis, pneumonia, bronchiectasis, all important for their common inflammatory pattern, as well as the liver presentation of the disease involving hepatitis, fibrosis, cirrhosis, hepatocarcinoma, and finally liver failure. Of note, we should highlight how, although the emphysema represents the main clinical presentation, we should be aware that typically alpha-1 antitrypsin deficiency may present with alternative respiratory patterns such as asthma, bronchial asthma, bronchiectasis, and we should also be aware that typically these different patterns may share some overlap features, and then the clinical suspicion should be raised according to specific clinical criteria. Just to give you a look, an idea on how the clinical presentation of the lung emphysema occur, the vast majority of patients present with a panlobular emphysema, bullous expression of emphysema occurring mainly in the lower lung lobes, and interesting, more than half of the alpha-1 antitrypsin deficiency population. Together with the panlobular emphysema, we should cite the centrilobular emphysema occurring in about 20% of patients and sharing different anatomopathological and clinical feature. Together with a very other than emphysematic presentation, we here cite the bronchiectasis that occur in about 4 to 8% of subjects, and again are characterized by an atypical clinical and presentation. Why all this awareness? Why we should raise our awareness in relation to the proper and early diagnosis of alpha-1 antitrypsin deficiency? Mainly because we have a treatment, we have a way to give a patient relief and slow down his disease progression by providing augmentation therapy consisting in an intravenous infusion of an alpha-1 proteinase inhibitors obtained from a human plasma pool of normal donors, having the following objective. Augmentation therapy is able to increase and maintain the serum alpha-1 antitrypsin level above the threshold we have already mentioned of 50 milligrams for deciliters. Again, the augmentation therapy has been proved efficacy in slow down the progression of emphysema and reduce the number of exacerbation. For those of you who are confident with the COPD natural history, we know that this goal is quite relevant in warrant a good clinical response to treatment. All these features and aims all together allow the clinician to reach the last main goal, that is improving the duration and quality of life, and as I'm going to show you in moments, even survival of the patient. We should say that currently guidelines and recommendations state that the replacement therapy should be only administered to those adults that already show clinical evidence of obstructive pulmonary disease and a very low circulating level of alpha-1 antitrypsin, meaning that probably we are going to currently miss patient with early diagnosis in a preclinical phase, and this is a pity because, as we know, when COPD and emphysema starts, there is no way to improve the clinical condition of patients and their lung function. Here are some very brief data on the feature of the replacement therapy. This is very good in restoring adequate alpha-1 antitrypsin circulating levels with concentration that are able to remain therapeutical up to 7 to 15 days. This meaning that at the moment the treatment is administered 4 to 2 times for months, and the patients restore their level. Once the alpha-1 antitrypsin is administered, we can easily see that this restore again the anti-neutrophil elastase capacity in the blood, this allowing a correct and the proper balancing of anti-elastase ability. And this is also certified in the study that show how augmentation therapy is able to reduce and to decrease the level of those inflammatory biomarkers involved in the lung failure and the emphysema pathogenesis. Under a clinical point of view, we should also highlight that replacement therapy is associated with a significant reduction in the progression of emphysema, as seen in this study conducted on CT scan. What we saw that the reduction of lung tissue loss in placebo versus placebo, is about 36%. That is not bad at all. Even more interestingly, the augmentation therapy is able to reduce the number of exacerbation, and this is known to be a relevant factor in slowing down disease progression in COPD patients. And finally, all these features taken together leads to an improvement in survival of these patients. And of note, the survival rate improvement is higher for those patients with worse lung function at the time of therapy starting. Of note, let's move from clinical side to lab side and see how and which instruments we have to perform a proper diagnosis of alpha-1 antitrypsin deficiency. The first important instrument is the measurement of circulating alpha-1 antitrypsin level, maybe together with the measurement of an alpha-1 antitrypsin elastase inhibitory activity. This is an in vitro inhibition, very popular in experimental setting, less popular in clinical practice. However, this is an instrument we have. Then we can also try to perform the phenotyping by using the isoelectric focusing electrophoresis. This is something I would like to talk about. I hope I won't make you upset about that. I'm just a clinician talking about such things, but I think that it could be important for you to share some information about this. Another technique is allele-specific PCR technique. This is in order to identify those common M, S, and Z alleles. And finally, we should provide a genotyping by direct sequencing of SERPINA1 gene. This to identify both common, but even uncommon, rare, or even null variants. This is the flowchart, the diagnostic flowchart suggested by European Respiratory Society statement and recommendation. This is obtained by pulling together all the recommendation provided by single national methodological works. This is important to see how a flowchart should be followed in order to provide a quantitative analysis first, followed by phenotyping and genotyping. However, there is a limitation in this approach that is mainly seen in this slide, where you can easily realize how currently testing is recommended for those patients who already have or show clinical feature of the disease. This meaning that performing the diagnosis at this stage probably is too late, and miss a number of patients that could be intercepted at the early stage before the disease becomes overt and clinically evident. For such a reason, we asked to ourselves whether there could be any room for a population screening that, bypassing a clinical feature, could be able to highlight and identify those patients with the suspicion of alpha-1 antitrypsin deficiency. For such a reason, we performed a population analysis of electrophoretic alpha-1 globulin band at electrophoresis, and we observed that the alpha-1 band mainly constituted and made up of alpha-1 antitrypsin has some quantitative and qualitative change in those patients suffering with alpha-1 antitrypsin deficiency. We were able to identify specific thresholds associated with a higher risk of mutation just by observing the alpha-1 antitrypsin, alpha-1 globulin band at the proteogram. This is another study that was very good in assessing the relationship and the sensitivity of alpha-1 band below the threshold of 2.1% in detecting the double Z phenotype. In other words, when the alpha-1 globulin band is below 2.1, there is a 84.2% sensitivity of being in front of double Z phenotype, meaning a very severe deficiency. Again, a similar approach was used in this study. It was made by our group, where we were able to detect, to obtain a 60% detection rate, identifying those patients with an alpha-1 globulin level below 2.6%. And this was very interesting in proving that an algorithm based on the alpha-1 globulin fraction was able to identify carriers of the PIM gene mutation. And this was done without any previous clinical evaluation or alpha-1 antitrypsin serum determination. This becoming potentially suitable for clinical and epidemiological purposes. That's, in my opinion, some very important take-home message. For such a reason, we therefore projected and planned, and this is currently ongoing, another study with a multicentric fashion and involving the center of Rome and Pavia, the coordinators, together with Perugia, Naples, and Palermo, all in Italy. And what we did is just replying the design of the previous study, using as a threshold the alpha-1 globulin band below 2.9%. And again, what we found is about 60% detection rate for all kinds of mutations, and 11% detection rate for severe homozygosis deficiencies. Okay, apart that, let's remember very briefly what's the instrument. What are the instruments we have to perform a proper diagnosis? We have to remember that the nephelometry assist. This is a very cheap, reliable instrument, but carrying some limitation. This is not something useful to detect heterozygosis, for example. So very often we should use a more performing instrument that is immunophenotyping, and use genotyping and sequencing for more detailed approach. However, what I would like to stress now is the importance of isolecting focusing electrophoresis for diagnosis of alpha-1 antitrypsin. And let me just give you a brief background on the principle that we need to understand this approach. Remembering that alpha-1 antitrypsin, again, is a glycoprotein made up of 394 single amino acids that are organized into three lateral and glycan chains. The glycosylation of the protein is very important in understanding how the isoelectrophoresis focusing may be used in this situation. And we should be aware that glycosylation in this case is a quite heterogeneous condition that leads to 8 circulating isoglycoforms of the protein. And this is very important, as you know, that each isoglycoform carries with a different isoelectric points. The isoelectric points is on the basic of the principle for isoelectric focusing electrophoresis, since this approach implies that a pH gradient is established in a gel before loading the sample. After the sample is loaded, the voltage is applied, and this causes the migration of each isoform to their isoelectric pH. And this is very important for detecting differences in polymorphism and even in mutation. This is how isoglycoforms appear and separate in a standard media. The homologous MM pattern that I remind you is the normal context is made up of 2 major bands named bands 4 and 6 and 3 minor bands, the bands number 2, 7 and 8. The band 2 is the most nodal and the band 8 is the most cathodal. However, it's very important that band 4 is by far the most prominent band seen in this pattern, together with the band 6. In pathology, when some mutation occurs, we should use the principle, keep in mind the principle that the patients with the most severe deficiency have some allelic variants that migrates to the higher isoelectric point. This compared to the M normal allele. Just to give you an example, you can see how, with regard of the M variant, the S variant provides a migration toward the higher isoelectric point, and the Z variants in even more located in higher isoelectric points. Just to be clear, we have several ways to perform the phenotyping, and we can also perform our homemade gel preparation by using agarose or and staining it with the Kumasi blue, or even using acrylamide and silver staining. But we should be aware that by performing this, we need to have time. This is a time-consuming approach. We have a poorly reproducibility in between the different centers, and we can also, have some problem when performing the test. Just to give you an example, we should be aware that very often the profiles of the phenotypes in alpha-1 antitrypsin could be really challenging in diagnosis by using improper methods. That's why I would suggest you to and recommend you to use validated and already tested approach, including the hydrogel test for alpha-1 antitrypsin phenotyping. This approach provide you with the ready-to-use gels. This approach is quite fast and very reliable, and allow you to perform detection with a specific anti-alpha-1 antitrypsin labeled with peroxidase. So this is making the approach very, very useful and easy. This is some specific indication for your commodity if you want to make more through this. What I really want to discuss with you instead is how to interpret the hydrogel alpha-1 antitrypsin pattern. I would start from a very important issue, that is that to perform a correct analysis and interpretation of results, you should always use the controls provided by the Sebia that gives you the controls for MM, MZ, and MS pattern that gives you a very, very reliable feedback on the position of the fraction M2, M4, M6, M7, and M8 that are very, very crucial for diagnosis. And similarly, you have the position of the fraction S6, S8, Z4, and Z6 for the pathological presentations. What you only have to do, basically, is just to compare the position of the bands of the samples with the one of the controls and see for the observed difference. Just to give you an example, look at how a normal sample is similar to the control, to the related control. This to confirm that the patients have a normal phenotype and no mutations at all. Here you can see other normal variants, and double check with the control that confirm you the diagnosis. This is an example on how the Z allele may appear and how the phenotype MZ can be seen at this test. What you need is just to have the control both for the MM and the MZ variants. And what you see is that the MZ is characterized by the Z4 and Z6 band. And as you see, the heterozygosis, is featured for a double band that represent the MZ and MOT, and together with the Z4 and Z6 bands. Again, you see another case, but in this case you are observing a ZZ phenotype. This meaning that you won't see anymore the M7 and M8 band, and also you won't see any M2 and any M4 band in the focusing, together with a Z2 band. Other examples, look at what happens with the phenotype SAM. In this case, what you are looking for is the occurrence of the S6, and the S8 bands. In the heterozygosis, these appear together with the normal variants, meaning M7 and M8. In the homozygosis, what happens again is the absence of the M2 band and the M7 and M8 band to be very, very weak or completely absent. And what you see very well is the S6 and S8 bands. Another potential mutation is done by the SZ phenotype. In this case, what you need is a control for all the three variants, MS, MM, and MZ. And you should keep in mind that what you're going to see are both the features of the two mutations, meaning the band S6, the band S8, the band Z4, and the band Z6. And here is how you see the sample of your patient. Basically, you see the absence of the M2, meaning that no normal variant is occurring, and all the features of the pathological variants, meaning S6, Z4, Z6, and S8. Please keep in mind that together with the main abnormal variants, also many other additional bands obtained from rare variants and variable difference obtained with rare mutation may occur. I don't want to go through in deep of this, but please remember that a number of anodic variants exist, and you should be confident with that when you want to perform isoelectro-focusing analysis and diagnosis of rare variants, but also cathodic variants exist, and again, you should be able to recognize them properly. Please note that this approach has been validated, and several studies prove how this works and how this is useful for proper diagnosis, and how this may facilitate the work in your diagnostic lab. So, in order to conclude, I would like to say that alpha-1 antitrypsin is a neglected, underdiagnosed, rare genetic condition that for sure deserve more awareness and attention in medical community, both of clinician and non-clinician. Diagnosis of the deficiency often occurs after an unacceptable delay and at an advanced stage, with the patients already displaying organ dysfunction and even failure. The early diagnosis, however, could be made available through the implementation of large population-based screenings and case-finding approaches. This based on validated, cost-sustainable, and widespread available diagnostic tools. Finally, remember and note that SPI and isoelectric focusing might play a pivotal role, and their usefulness for this purpose should be highlighted and persecuted. Thank you for your attention.
So, thank you, Professor Scarlata, for this very interesting presentation. I have a few questions for you. So the first one is, is the A1AT elastase inhibitor activity assay strictly essential in the clinical practice? So how do you use this kind of test in your routine?
Pardon, which test you said, pardon?
So the A1AT elastase inhibitor activity assay.
Okay. The anti-elastase inhibitors, what we usually experience in clinical practice is that many patients display a poor anti-elastase activity, despite you don't see any specific change or mutation. The reason for this might be manifold. It might be a very, very high influence of exogenous interferent with alpha-1 antitrypsin and anti-elastase inhibitors, that is smoking. Even not actively smoking patients may have some detrimental effect of passive smoking or exposure, and this may affect their anti-elastase activity. In such a situation, you can try to test directly the efficiency of the anti-elastase by performing a specific test. However, I would say that this approach is mainly limited to experimental settings and not in clinical practice.
Okay, thank you. Another question is, so for which type of population the SPE would be particularly interesting in order to screen patients for alpha-1 antitrypsin deficiency?
This is an important point I would like to highlight. In my opinion, we should think about performing large population screening. Again, I would like to stress the concept that by applying the current guidelines, we perform most of the diagnosis in patients who already have clinical features of the disease. This meaning that we have a limited clinical and therapeutic chance to influence the natural history of the disease. For such a reason, if you would be able to perform an early diagnosis by performing large population screenings, just remember that electrophoresis is a test which is performed for many different reasons, just for screening before surgery, for example, or for screening in blood transplantation or in plasma donors setting. This meaning that if we perform a large screening in selected populations, we probably might be able to detect some deficiency in a very early stage, and we may therefore playing a relevant role in prevention and disease prevention, respiratory, both in the respiratory and the liver and the hepatologic field.
Okay, thanks. So another question for GP, for general practitioners, what follow-up should be provided for carries, for people that carry the genotype? Is there any recommendation in terms of follow-up for this kind of patient in case there is no clinical symptom?
Another very important issue, we should remember that most of the patients do not have a very severe respiratory patterns at the time of first diagnosis. Very importantly, we should be able to follow up these patients, performing repeated measurements of circulating alpha-1 antitrypsin, and the lung function should be monitored in time in order to address those patients displaying an accelerated lung function decline. And please remember that spirometry is a very important tool, but please also remember that flow volume curve by itself alone is probably not the best instrument to assess lung function in these patients. The FIV determination could be misleading. Much more important is another test, that is the diffusion capacity for carbon monoxide, that is probably much more precise in defining the smaller change occurring over time in these patients and identifying those patients more likely to develop overt disease in the future.
Okay. So another question that we have. So do you think that SPE, so 0.7 protein electrophoresis, could maybe replace in some ways A1AT quantification based on your experience? So what are you, how do you position or do you use in your routine to develop?
No, I don't believe that it should be an alternative approach to what we already have. I think that this should be used as an integrative tool, and that its priority should be assessed according to the objective we have. I'm quite confident that this should be a very, very good and a performant approach in large population screening programs. Of course, if you are clinical, if you get your patients and you get the clinical suspicion, you should still use the alpha 1 antitrypsin determination and the classical traditional diagnostic tool approach.
Okay. There is also one question related also to COVID-19. So the question exactly is, so did you see any correlation in the past 3 years between a certain A1AT phenotype and susceptibility for medium to severe COVID infection in case they have been infected?
The ARCO project, I don't know if you saw my first slide. I'm a member, a proud member of the ARCO project that is really active in performing research Europe-wide on this topic. One of the projects that were taken during pandemics, I think it was held by Professor Marc Miravilles from Barcelona. He's a really opinion leader in the field, and was able to investigate such an association. What we saw is that it doesn't seem any higher responsibility to COVID infection to exist in the subject in the deficiency. Of course, if alpha 1 antitrypsin deficient patient gets the COVID, the exacerbation that follows can be very challenging for an already damaged and poorly performing lung. Of course, we are talking about a rare condition, so we are still waiting for data accumulation and more evidence, stronger evidence.
Okay, thank you. And the final question for you. So, how do you use basically genotyping and phenotyping in your routine? So, in which context, particularly, do you think that phenotyping has a stronger clinical value?
Yes, of course. However, if you want to consider, at least in Italy, if you want to consider the augmentation treatment, you have to prove the patient is suffering from a specific mutation. So genotyping is fundamental in Italy to provide the patient with the treatment. Again, we know how a specific genotype associated with a faster lung function decline. It is very important the patient know also for counseling and for defining the best strategies in follow-up. So, of course, genotyping is somehow important in defining the proper approach and even for defining the phenotype of the patients that is made together with spirometry, with the 6-minute walk test, with the CT scan, with the liver assessment, and so on.
Okay, thank you. Thank you for your answer. So thank you for your very interesting presentation today. So it's time to close the session soon. But before closing this session, I would like to inform you that in a few minutes, you will receive an email. So this email will include a very short link, a link to a very short survey, and it will only take you very few minutes to fill in. It's very important to get your feedback for us in order to adapt also our webinars and communication in the future based on your needs. And for your information, this replay, this webinar will be available in replay in few days. So you can watch directly after the event, but we will also upload this event and this webinar in few days on Sebia website. So I would like to thank you all for attending this webinar today, and particularly thank you very much, Professor Scarlata, for your very interesting presentation. And I wish you a very nice day to all. Thank you very much.
My pleasure. Thank you. Bye, everybody.